Well, welcome everyone to the EMS Interoperability Task Force call for November 2023. I'm Josh Legler. I'll be facilitating the call today as usual. Looking forward to the topics that we have up for discussion today. As a reminder, this meeting is recorded and it will be posted on the NEMSIS YouTube channel. If anything comes up that you need removed from the recording, just let us know. We're trying to use a mostly moderated format, so we really encourage discussion throughout the call. If you could use the raise hand feature in Zoom, we are happy to recognize you and give you a chance to speak. And then, of course, there's the chat area. We'll try to monitor that as well. Let's see, I want to make sure we get Christina Caraballo in from IHE and HIMSS. Welcome, Christina. I think we just got you in. Just a couple updates here at the beginning. Wanted to let you know that Amit Trivedi is no longer with HIMSS and IHE, so we won't have him with us on our call today. However, we are pleased to have Christina Caraballo with us. She's the president of IHE USA and VP of Informatics at HIMSS. And so she'll be joining us today. Christine, would you like to introduce yourself? Anything you want to say?
I was muted, sorry. Hi, Josh. Thanks, everyone. Happy to be here. And as Josh said, I will be joining with my colleague, Emily Loomis, as well, who's been participating in these and very familiar with the work that's happening. And we've been very excited at HIMSS and IHE USA to share the EMS interoperability as one of those core groups that really needs to be incorporated into the health ecosystem. So really looking forward to figuring out how we continue to engage with the community. And I will be on listen mode as I kind of get up to speed here. And feel free to just ask me anything as I understand better what the group's doing. But I did take a look at the Google meetings before this and already am starting to think through some ideas. So thank you.
Thanks, Christina. Wanted to also just give a chance to introduce any people who are new with us who haven't been participating in the task force calls in the past. I wanted to mention that we have the team from CareEvolution led by Trent Gavazzi. I don't see Trent on the call yet. Is there anyone else from CareEvolution who is on the call at this point?
Hi, yeah, it's Jessica Sturka. I work in marketing at CareEvolution. I work closely with Trent.
Yeah, we got a few of us here from the tech team, so we're pretty good on our side. Hi.
Okay, great. Welcome. And any other participants who are new today who would like to take a moment to introduce themselves?
Well, this is Chris Milo from Philips Healthcare. Joining, I just heard about this initiative through IT PCC domain, and thanks, Andrea, for linking me in. So might have a couple other representatives also from Philips joining going forward.
Fantastic. Welcome, Chris.
Thank you.
Hi, this is Karen Burnett from ImageTrend. I'm working on the product management team and am joining my colleague John Hodgkins on the call as well.
Great. Welcome, Karen. Okay, any others? All right, well, let's get started with our call today. So just at the 30,000 foot level, the overview of where we're at so far. As we've been working through our monthly calls in 2023, we've covered a ton of topics. We spent the last few months looking at the standards and profiles that would be used for handling the content that would be shared from EMS to a hospital, from a hospital to get outcomes to EMS, and at the beginning of an EMS call to get patient history to EMS. And so today we're going to go to the important topic of patient identification and record matching. So this is at the beginning of the EMS call. We need to figure out who this patient is and then get some medical history about the patient. So how do we actually identify the patient in a network so that we can get some records, medical history information for that patient. So that's where we'll be mostly today. We have a few other things that we're going to hit on at the beginning of the call, and then we'll jump into that topic for the bulk of the call today. Looking forward to next year, we're going to start talking about the specific data elements that would be important to clinicians in these steps of the workflow. And I'll talk more about that at the end of today's call to see if we can get some people lined up to help us with those topics. Okay, so a little bit of upfront stuff before we dive into that main topic. First, a reminder of the ONC Annual Meeting coming up on December 14th and 15th in Washington, D.C., and also the EMS Data Summit that's being held in conjunction with that meeting at the same location in Washington, D.C. That'll be on the afternoon of December 15th, and you can attend in person or online. So you can follow either of those links or both of those links. If you register for the ONC Annual Meeting, you would also need to register separately for the EMS Data Summit if you'd like to attend that. Or if you want to just register for the EMS Data Summit, that's fine too. Just a quick note, we originally had scheduled the Data Summit to start at noon. We've pushed that till 12:30. We learned that people will need to go off-site for lunch, and so we'll give a little bit of time for that to happen. So 12:30 to 3:30. And just to give you a little bit of a heads up of what we're looking at for the agenda, we'll have some presentation from the Office of the National Coordinator for Health IT on opportunities for EMS and healthcare interop, looking at TEFCA, USCDI, USCDI Plus. We'll hear about interoperability from the EMS agency perspective, really looking at the benefits, why it's worth doing all this, interoperability current status, and next steps from the network perspective. And we'll have state and national network perspectives represented. And we'll finish it with a panel of all presenters looking at addressing EMS interoperability opportunities going forward. So I would encourage registration and participation in that data summit. So far, we have about 80 people registered for in-person and another 80 registered for online participation. And that's a great show to ONC that there's a bunch of people that care about getting EMS connected to the rest of healthcare in terms of their data sharing. So it's great to see. Okay, one other thing we'd like to cover up at the front here is the HIMSS24 Interop Showcase and next year's IHE Connect-a-thon opportunities. Phil DiPaolo has offered to share some information on that, and then Christina Caraballo might chime in as well. Phil, are you ready?
Yes, and so I can certainly start by speaking to the Interop Showcase, and of course with Christina and Emily on the call, I think they can handle the IHE Connect-a-thon portion. So I can just briefly start by saying, my quick background as an EMS provider, I've been a paramedic for almost 20 years. When I first kind of got into the healthcare IT side of things, my dissertation work was all about, interoperability in transport medicine and kind of helping partner some of the original older IHE specs, and then certainly excited to see that work, coming to fruition even more heavily now with, what Andrea has done and the rest of this task force. So it's really exciting to see this here. We've always tried to get EMS vendors into the showcase in the past, and certainly it seems like that has happened a bit more frequently in the past few years, which is also pretty exciting. And so, I can just simply offer that from the HIMSS24 global conference that'll be coming up in March, that the Interop Showcase is certainly open to vendors to join us. I know we already have at least one EMS vendor who signed up who was with us last year, and that was Image Trend. They did some groundbreaking work alongside Epic at the previous IHE Connect-a-thon, working on those connections between the two of them, and they were definitely able to demonstrate that nicely in our showcase last year. So while I'm sure they would appreciate having no competition in the space per se, we would love to see additional vendors supporting the EMS task force and demonstrating that work at the Interop Showcase. But I want to just remind everyone that the work we demonstrate inside the showcase is standards-based exchange. As such, doing that background work, that leg work to make sure that what you're demonstrating has been tested and validated and is not proprietary is like the number one requirement for joining into the showcase. And so, with each vendor who comes into the showcase, we always do a little bit of onboarding to ask how they've, done this, et cetera, so that we make sure that we really hold that bar. And in fact, this year, we are increasing that bar by asking every vendor to complete this attestation form that we've developed to show us how you've done that. And that can be a variety of things, whether it's tools you've used, sandboxes, attending an IHE Connectathon in the past, or a Fire Connectathon to work through some of those use cases. Any of those options are certainly available in completing that attestation form, just to show us that you have been working on this and it's not just brand new, or that you really haven't done this and it'll require a lot of effort once you actually work with your partners. But again, assuming that vendors can kind of meet those requirements, then it's available and open opportunities to anyone who wants to sign up right now. And it'll be exciting to get involved this year because we have re-envisioned the showcase. I think Christina mentioned earlier on the call the idea of the ecosystem. And so with that concept that she provided, we really developed how the showcase looks based around that healthcare ecosystem to make sure that we're really touching every aspect of how interoperability is carried out in healthcare. We have supporting areas that we call enablers that are usually the backbone. So like HL7, IHE, organizations like that, or maybe like a Drummond who does a certification, those kind of folks, and how they promote and enable interoperability to happen, all the way to, of course, the connected sponsors who come together to actually do that work and demonstrate a bit of their use case and how that shows interoperability, improving those patient outcomes. And so this year, like I said, I think it's going to be a fun new format, definitely a new design. So it should be eye-catching. It's also, I want to say, front and center. If you've been to the Orlando Convention Center, you may notice it takes about 7 years to walk from left to right. And this time we are right in the middle of the convention hall. And so it is a pretty awesome, prominent spot. One of the main 20-foot aisleways comes right through the front of the showcase for easy access. And so we're very excited about that positioning this year. And again, we believe that our changes in how we present the demonstrations will allow vendors to receive more value. They'll get more ability to demonstrate more often. The leads that will be generated from that work should be more valuable as we increase our wayfinding so that attendees are able to connect with vendors that are really looking for each other. And again, I think this is all will make it a very fun opportunity if you have not previously participated in the showcase and you're looking to get involved this year. We can share afterwards or in the notes. I unfortunately don't have the link to share right now, but we have a sheet that kind of just shows you the different themed areas and how you can jump in and participate. Excellent. Thank you so much. And so this shows everyone where you can kind of jump in. I always want to mention this sheet is something we just kind of draft as a high level intro document, if you will. If you see the roles that are listed there and you're like, well, we do something a little bit different, then no problem. There's basically about 12 spots per health pathway. And we've listed about 20 roles for them. So you can see we've sort of overestimated. And again, oftentimes we will allow others to kind of come in and let us know exactly what they're doing as we fill them in. We have foundational sponsors who are there really to support the crux of the showcase itself. Those are usually larger EMR systems. So for example, Epic, Oracle Healthcare, previously Cerner, are coming in as foundational sponsors. And so, if you're looking to interact with one of those two major EMRs, they would be prominent throughout the entire area. You may not see them listed just yet as they're coming together with their teams to decide exactly where they want to be positioned. But, if you have additional partners or vendors that you work with, that's awesome. It's great to bring them in together as partners and pairs. That way you can tell the story that really means everything to you. And that's, again, another one of those benefits. We are really allowing each vendor to really tell their own story, because we won't be doing a presentation with 8 other vendors and you all kind of fit into the storyline. The presentations are broken down into those smaller bite-sized chunks. And that way you can tell the story you want to tell with your partner. And that'll allow you to really kind of hone in exactly on what you want to demonstrate. So again, I know it's a lot of information. Again, it's open to sponsorship still. You can certainly reach out to myself, Jody Tozer with Informa Markets, who is running the HIMSS Global Conference this year. She's certainly a contact we can reach out to. And then certainly we can position you with sales as well in order to get you into that and to get you the information or get you onto the webinar list. If you haven't attended a webinar in the past, we'll be doing another one in December. We certainly can share previous webinar slides as well. And so I'm going to pause there. I don't know if there are any questions specifically about the showcase, but then I'll give an opportunity for Christina and her team to talk towards the IHE part.
Any questions for Phil? Okay, sounds good. Yeah, I'm just excited to really show that EMS is part of the healthcare ecosystem. And I think the Interop Showcase is one of the ways to do that, where participants at the HIMSS conference will recognize that there's an EMS phase that happened in someone's care that was given to them, and that there's data from that phase of the call, and that EMS needs to share data and receive data. Great. Okay, so Christina, anything you'd like to share about the Connect-a-thon?
Oh. Can you guys hear me? Sorry about that.
Yeah.
I didn't know I was on the agenda today, so I don't have any slides or anything, but we are hopefully looking to make an announcement for our IHE Connect-a-thon in the next couple of days for 2024. So nothing to share today specifically, but I will say in my experience from last year at our event in Austin, one of my most exciting moments was when the Image Trend team came up after they had passed their testing and profiles. So really exciting about having the EMS interoperability and the profiles being tested. And we're excited to continue to build that and get more and more folks involved. So really love to hear your interest. Feel free to reach out to me directly as we're looking to build the testing plans for our upcoming IHE Connect-a-thon. It would be great to just understand who's interested and what vendors would like to continue testing. So hold please for more update that we will send via email, and happy to answer any questions.
Sounds great. So particularly for the EMS software vendors, if you have any questions about what it means to participate in a Connect-a-thon, or what it means to participate in the HIMSS Interop Showcase, or if you have any kind of barriers or challenges that you've seen in participating in those opportunities, feel free to ask those questions now.
I'll throw out a question.
Yeah.
Hey, can you clarify so that there's no confusion what the costs associated with this are? Last time I tried looking into it, sticker shock would be a nice way of putting it.
Sure, I can address that question in reference to the showcase. Our connected level sponsors, and I might be off by $100 or so, they're right around the $11,000 mark to participate as a connected sponsor within the showcase. There's a 10% discount if you're a HIMSS corporate member that comes along with that. But you're in that range for the connected participation. Since you did ask that question, though, I might also add that with our re-envisioning, in our opinion, it seems from all the work that's usually done, is that while that registration fee is certainly a part of it, maybe it's actually not the most expensive part of it. It's the resources used in the development process prior to the actual showcase. We typically begin those meetings a few months out that are weekly, and that might be resource intensive for those who are participating. We do imagine and expect with our new process that the concept of those weekly meetings goes away. And so we just expect there to be less internal company resources spent on putting this together than there has been in the past. The pricing is pretty much the exact same as it's been, so that doesn't change. And then the only other caveat is if you're looking to participate in more than one demonstration, there was previously a discount for that. Now it's just that same cost multiplied by how many times you want to be in a different kiosk or area. And of course, that comes with a number of badges. I think it's like 6 conference badges or some various combination of such, and a few other benefits that go along with that participation price. But yeah, so I would say that the connected sponsorship level is at 11,000. If there is an EMS leader that wants to join in at our leadership level, we'd love for that to happen. That definitely comes at a price point that's much higher, but it allows you to run your entire demonstration with a huge turnkey space. But then you're up in the $80,000 range. It allows you to invite in 6 additional partners at no additional cost, et cetera. Some organizations are actually taking us up on that and then internally splitting that cost up among those organizations. But I imagine that price point probably does not make sense for the majority on this call. So I hope that helps answer that question.
Yeah, thanks, Phil. And Christina, I don't know, it might put you on the spot, but if you have any comments about costs for Connectathon participation.
Yeah, I can. Historically, our costs have been $7,500 for the first system and $3,000 for each additional system. We are looking at. I would operate under those assumptions for now until we get the actual registration posted.
Okay, great, thanks. Other questions from vendors? Okay, great. Thanks. One other quick topic I want to hit on before we get into today's main conversation topic. Back in April, we talked, the idea came up in this task force call about creating a letter addressed to the Office of the National Coordinator for Health IT that would represent kind of a position statement about the readiness of EMS to engage in interoperability with the rest of healthcare. So it took a while to kind of work at the federal level and figure out who would be the sender and who would be the receiver of that letter. It was decided by NHTSA that this would be a letter that would go from NHTSA to ONC, so it would be federal to federal office. And so that letter has been drafted and is kind of working its way through the federal process. I've listed here the key points that went into that letter based on all the conversation, all the input that all of you gave in that April task force call. So really, touching on how important EMS is to the overall healthcare ecosystem, the readiness of EMS to participate, the value that EMS brings in terms of the data that it holds, the needs that EMS has. And I'd say kind of the requests in this letter are these last 3 bullet points on this list. The need for EMS to have representation in federal health IT policymaking, including TEFCA. The need for timely data because EMS is an emergency situation. And the need for responses to healthcare operations queries so that EMS can get outcomes from hospitals after the end of an incident. So that's just kind of a snapshot of what went into that letter from all of your input. And I hope that this will represent, that as you look at the things on this list, that these are things that you agree with and that you feel like would be worth highlighting for ONC. So just wanted to bring that to you, but I'll just open it up now if there's any comments on kind of what's in this letter. All right, cool.
Hey, Josh.
Yes.
It's Aji. I was just trying to get off of mute there quick. No, it's been great to see the progress on the letter and getting some feedback and everything on that. We'll be anxious to, get to the next phase where we can get everybody's agreement on some of those things that we want to have when we think about operations query and stuff like that. But this is an awesome start on this. So thank you guys for the effort.
Yeah, thanks for your contributions. All right, well, let's jump into today's main topic. So we're looking at the standards and profiles to use in the patient identification phase of the EMS interoperability workflow. These are the questions I'm hoping that we get answered today. So just knowing what standards and profiles are used for figuring out who the patient is in a network. How do master patient indexes work and how is that relevant to EMS? How will patient identification work most of the time on EMS calls? What I mean by that is all those times where you have a driver's license or whatever, some fairly good information about the patient's identity. And then also, how will patient identification work on EMS calls where there isn't enough information about the patient? And maybe by the time you got them to the hospital, there's still a John Doe from EMS's perspective. How do we later kind of figure out who that patient is and still be able to get outcome data from the hospital on that patient? So that's kind of the overview, what we're looking at today. In terms of discussion, we're going to hit this in 3 directions. I'm going to briefly walk through the sequence diagram that we've been looking at the last few months and review the profiles that are listed in the patient discovery phase of that diagram. I don't have a lot of personal knowledge of these profiles, and so I would ask for input as we go from those on this call who have used the profiles, if you can help fill us in on, how they're used in the real world today. We will turn some time over to Lee Prosh from ESO, who will explain some concepts around enterprise master patient indexes. And then to CareEvolution, they have some information, just considerations around the patient identification step of the workflow. That's what we'll be looking at today. Okay, so this is our sequence diagram, the patient discovery phase. And so this is where EMS is trying to look up a patient who they are responding to on a 911 call or interfacility call. They try to figure out who this patient is, and then they look for that patient in some kind of health information network or HIE. And the network responds with matches for their search, and they need to figure out the right patient. And then what you don't see in the workflow here is the stuff we've already talked about, which is that you would then request medical summaries for that patient to get their medical history. Well, obviously, we need to get the medical history for the right patient. That's really important. And so this patient discovery phase is critical. There are 4 IHE profiles listed by their abbreviations there in the yellow box in the top right. So I'm just going to briefly kind of spell out those 4 profiles so we'll know what they're talking about. And again, those of you on the call who have experience with these profiles, I would love to have your input to just let us know how they're used. Okay, so first, XCPD is cross-community patient discovery. And that's an IHE profile that supports the means to locate communities which hold patient health data and the translation of patient identifiers across communities holding the same patient's data. Anyone on the call who has some experience with this profile and could kind of fill us in on how it's used in the real world today?
Hey Josh, this is Bindu here from CareEvolution. And we are pretty familiar with PICS XDS and XCPD, XCA based exchanges through our state implementations and also private HIEs. So I can talk to a little bit of what this is. So this is kind of a case where you're going to a community, a different community. It could be something on the eHealth exchange. It could be a Commonwealth community. And you're just sending patient demographics that you have. And this is where it becomes important to obviously send, like you said, as much information as you have to allow the responding. So what you are doing is initiating. You're an initiating actor, so to speak. It's an initiating gateway from your side, and you're talking to multiple communities which are acting in like responding gateways. And they get your query and they'll give back information about whether they know the patient or not, some demographics along with identifiers. Once you determine that that is an adequate match, you can use the identifiers to then make your XCA or cross-document queries.
Great. Yeah. So this is where the EMS provider's software might be connected to a local HIE, and then but that query might go from that local HIE out to across a national network to other communities. Right. Okay.
Yep. Yep. So what, in that sense, what you are is a node in the local HIE, and the local HIE is taking the responsibility of connecting you out to other communities.
Great. Yeah. And then Steve from Wishin said, which is the Wisconsin Health Information Network, he said that his network uses XCPD all day, every day.
Right.
Okay. The next abbreviation is PDQ, patient discovery query. This is also an IHE profile and provides ways for applications to query a patient information server for a list of patients based on user-defined search criteria, and then get their demographic info. As I was kind of looking through the profiles, I thought that this was probably the profile that would be most relevant to the software vendor of a local EMS agency system, that they would be putting in this patient discovery query into a network. Does that seem accurate?
It could be PICS or PDQ. It just depends on whether you've declared, the patient from before and you've sent a patient identity feed, then you can query using the identifier, but PDQ lets you query using demographics.
Okay, great. Thank you. Anyone else with comments or experience in the patient discovery query?
So this was one of the ones that I was looking at a few weeks ago. And one of the things that I think was important to know is that the PICS is to, like she was saying, the previous person who was talking was saying that, you use an identifier to do that query. So you submit the demographics and then receive an identifier back from the network, and then use that identifier to query for the patient's records. In the absence of that specific identifier, you just would be using the demographics to do a demographics link to the record. So it's a similar mechanism. It's just based off of identifier versus demographics, and the strongest would be PICS, but you can also use PDQ.
Okay, great.
And Josh?
Yes.
Sorry, Steve Rotman at Wishin. You can also use, and what we require in Wisconsin is an ADT as a replacement for a PICS query. So there's an ADT message that precedes a request for documentation. That's the way we identify patients, rather than a PICS, is using an ADT message. So there's a preceding visit or patient treatment relationship that's established before receiving a document. And that's essentially what we've built in the conversations I've had here with ImageTrend for the Milwaukee Fire Department, that there's an ADT and then there's a subsequent request for documents.
Oh, okay. So the EMS software is sending an ADT that is kind of establishing that, hey, we have an encounter going on, and then following that up with a query for patient discovery.
Correct. So, many ways to skin the cat, I guess.
Yeah. Okay.
And
Well,
PICS,
sorry.
yeah, I'm sorry. So PICS version 2 is essentially a pared down version of HL7V2 ADT without the visit information. It has mainly the patient demographics. And like Steve was mentioning, a lot of HIEs, and at least one HIE I've worked with, we've tried to see if we could get ADT instead because it's a richer source of information, and we've leveraged the incoming ADTs for other kind of outbound alerting. So if we have a hospital admit event, we can alert the PCP of record, for example. So yeah, it works. An ADT as a stand-in for a PICS feed is a common scenario.
I'll go ahead and flip to PICS, which was the next one on the list. So patient identifier cross-referencing, another IHE profile. Cross-referencing the patient identifier across multiple domains. Let's see, Jonathan, you had mentioned in the chat ADTs maybe being problematic for EMS agencies.
Yeah, I don't like ADTs. So in fact, I've done a lot of writing on this in other places. ADTs, the closer you push toward an ADT oriented model, the more asynchronous your data becomes. And this actually is something that we talked about. In fact, Doug Butler and I talked about this at their booth, ironically enough, last year at the HIMSS thing, because they were showing off ADTs, and the challenge that came up, and if no one knows what I'm talking about, there's an article that came out about that I'll be happy to share in the chat here. But the requirement to enter sufficient data about a patient in order to create and transmit a ADT in full does not necessarily jive with EMS workflows in the field. So that was a pretty important part of the discussion, is the idea that I need to have the ability to capture enough info. If your software system, if your EPCR allows you to do that, and you are using it in the truck, then you can do that. But we know, for example, that about 50, in fact, Josh, I'm going to pick on Oregon. We know that about 50% of Oregon's agencies use ImageTrend, and 50% of those use it back at the station after they've handed off the patient, and they're sitting down at the desk to do their charting. In that case, you've got at least 25% of providers in the state that essentially are not creating an ADT that timely matches the arrival of the patient. That's a real problem. So it's not a technical problem there. The ADT doesn't have a problem from a communication standpoint. It has to do with a timeliness issue, whereby the patient may already be admitted by the time the ADT has arrived. Because if you're going back 20, 30 minutes to your rural station, wherever, then having some coffee before you sit down and write your chart, you're not going to get that ADT. Then you may have already seen the patient. They may have already left the ED, et cetera. So there are real issues with the reliance on ADT as a communication method in the real world. While they are just fine, perhaps from a technical perspective, they're effectively useless until such time as you get everybody charting at the patient's side. It is a workflow issue, Andrea. That's exactly my point. So to the degree that we can make everything theoretically possible, but EMS, this is a big topic, and I have a different hat that I wear when it comes to California, where I'm representing certain important parts of the fire EMS ecosystem here to the State Data Exchange Framework Stakeholder Committee. And this has been a very important part of the discussion, is you can build all the tech you want, but if the crews in the field can't do it because it doesn't jive with their reality, then it doesn't matter what the rules say, which is why we've had laws after laws after laws in California to get people charting in the field. But in the rural environments, AB 1129 doesn't do anything because you can't get a network connection. You're not going to be able to take your free software that you are using only online and take it into the rural areas and document. So doesn't matter which vendor it is, doesn't matter how much it costs you. If you can't use it or you're not using it at the patient's side, the ADT won't work. I think that's one of those realities that we just need to disavow ourselves of. It works very well in a facility-based environment. It effectively is useless in a mobile medical environment. Sorry to remain on that.
No, that's fine. The workflow diagram kind of shows, you know, that EMS is identifying the patient up at the beginning of the workflow, but as you pointed out, that's not always the case. We also want to make sure that we can support scenarios where EMS may try to identify the patient after their call has ended, and they still want to be able to identify the patient so they can get outcome data from the hospital they took them to. But that identification step then happens, you know, significantly later in the workflow.
Oh. And Josh, I think that's, you know, it's worth, because Steve made an important point insofar as establishing the care relationship. That's certainly relevant here. But again, as I've summarized it, you've heard me summarize this many a time from a stage. One of the most unique aspects of the mobile medical context is it's the only aspect of American healthcare that routinely deals with the unknown patient. That's not really a negotiable point. It's just a reality of mobile medicine. So to the degree that Josh decides that today he's John F. Kennedy and he's not actually John F. Kennedy, he could be John F. Kennedy. I don't really know that. I might want to look him up. But if it turns out he's not John F. Kennedy, then we can't trust what he has to say. And therefore, we can't use his identification information for anything. But this was a discussion that came up pretty vociferously at the Manifest Medics conference out here in California a few months ago. Where, again, you've got facility-based engagement and non-facility-based engagement, and break glass doesn't apply if I have no idea who you really are. The actual answer to this question, by the way, Josh, if you want my opinion, is we should be talking about biometrics. We shouldn't be talking about anything other than that. So to the degree that I can use a finger, a toe, an eye, or your face, unless you've been involved in major vehicular trauma or you've been stung by over 100 bees, I should be able to, and you have no eyes, I should be able to get your biometric to provide this information. Until such time as we're relying on ambulance or fire-based providers to have to figure out who you are, the ADT is very problematic in reality. Again, the model that ImageTrend showed the ADT, but when asked, how would you do this if you don't know the patient's identity, in X percentage of cases where you've got a GSW or a vehicular trauma or a stroke or a cardiac arrest, et cetera, the answer was you need that first. Or you need to push through temporary data. So you're putting John or Jane Doe through, that starts the relationship, but you're not going to reconcile anything and be able to do anything with that information until that identity is established. So again, these aren't really negotiable technical points. They are workflow issues, to Andrea's point. Those workflows are, they're ace, jack, queen, and king. It's the whole deal here. The tech is pretty easy.
Yeah, thanks. There have been a few comments in the chat, which I probably won't be able to summarize adequately. So anyone want to kind of chime in verbally with some of those comments?
I can probably come in. One of the comments that I was just essentially saying is that even though you go through your charting and charting may not be completed until way after the call has been finished, there are certain ways to design software so that once you've obtained and confirmed an identity, that you can be triggering these ADTs with your technology on your lap without having to close out the chart first. And the workflow issue is mostly because there's no benefit right now, theoretically, for EMS providers to be going through the identification process with their patient to obtain anything out of it. Then right now they would put it off till the end of the call if all they have to do with it is finish the report with that information. So it's a workflow culture and UI design issues when we're talking about not being able to complete either ADTs or any of these profile transactions until you've closed out that report. We're talking about being able to incorporate these elements into the workflow of the providers so that it's not you have to finish your report to generate this transaction. So these are the main points. And then Steve Rotman also says that, one size does not fit all, and there's always going to be opportunities to find like common minimum solutions. So this is the solution that we're talking about is in the case where you can obtain a reliable patient identification, like you said, Josh, through a driver's license or whatever, and whatever you have. Even biometrics can be used to generate something. You still have to use these transactions and messages to get things into and out of any national networks or HIEs. So just to be aware that like we have these issues, but we shouldn't let the unknown patient prevent us from continuing to find a solution that we know works for healthcare and healthcare providers for known patients and the ability to identify them.
Yeah, thank you. I was going to ask, I think you answered it, but my question was looking at whether EMS is identifying the patient up at the beginning of the call, or if they're identifying the patient later in the call, would these IHE profiles still be applicable in either case?
So they would be most applicable at the beginning of the call because PICS and PDQ are used so that you can retrieve the patient medical history that you're trying to query at that point. It doesn't mean you can't use them at the end of the call to establish an identifier and try to fill in holes from your report at the end of the call and say, that took 5 minutes and now I need to see what their medical history is so I can document this case. You can do this at any point, but the most valuable point would be at the beginning of the workflow.
Okay, yeah, because your intent is to try to get medical history on the patient. But your intent can also be that you just want to identify the patient so that down the road you can ask for their hospital outcome. Would that be done through these profiles, or would that be done a different way?
That would also be done through these profiles. So okay. This would be at the beginning or at the end or in the middle, wherever you want. There's a part of that workflow diagram that they don't really establish. We don't have it really mapped out very well, but you would do something similar with a PICS feed, where if you want to upload your run summary to an HIE or a national network, that you would have to make sure that you have the identifier or cross-identify that patient with existing records so that you can establish that this patient is connected to those other records. This would be something that you would have to maybe do at the end as well. Depending on when you do it, you just want to make that connection between the records.
Yeah, thanks. In the interest of time, I'm going to briefly just cover Patient Master Identity Registry, PMIR. So that's for creating, updating, and deprecating of patient master identity information. And I have a hunch that when we go to Lee talking about Enterprise Master Patient Indexes, this might come up. So that was the last of the abbreviations in that stage of the workflow. I feel like there's still probably a lot to unpack in those IHE profiles. And so, so I think, I don't know, we may need some more on that. I do want to make sure that we can get to the other two presenters that are queued up for today, but let's see. Jonathan, you had one more question for Andrea?
Well, I think, first of all, as I just noted, she makes a very strong point that's under-addressed broadly, which is the difference between technology and design. So I certainly want to thank her for pointing that out. The design choices, product design cycles and expectations is a topic worthy of discussion. And I think that's something we don't separate those two enough. There is a lot of, in fact, that's a big problem that NEMSIS faces. This is a bigger topic than now, but right, the underlying data set versus the way it's used by vendors. But the part that I found I wanted to understand a little more is where she mentioned something about how agencies aren't finding the utility in doing documentation in real time or at the patient. That I'd like to understand more what she thinks, because I would dispute that if I understood the way it sounded. Andrea, can you elaborate on what you meant by the idea that agencies aren't? Because again, I feel like this is one of the challenges we have here, Josh, is you got a lot of different people here, a lot of different agencies and companies represented. And it is there's a lot of different feelings on that. And so whereas there may be some, I mentioned Image Trend in Oregon, because I happen to have that number that I know. But there are certainly organizations doing patient care documentation at the side in real time, connecting with group systems like Pulsera that are front loading that even more. So I think that's a very broad brush, and I want to understand a little more about what that was. That seems worthy of a pause, especially if we're talking about real time versus not real time data entry here.
Well, I was just saying that based off of what you were, one of the points where you were saying when the identification of the patient is pushed off to the end of the call. And in the cases of the identifying the patient at the end of the call being that you're not getting a right hit or you're taking too long, or if it's a question of the provider saying we don't have the time to identify this patient, we need to provide their care right now instead of getting that information at that time. I'm mostly saying that if there's an instance of providers not identifying the patient at the beginning of the call, or not establishing that identification link in the beginning of the call, it is either a cultural issue or a technology issue. And the cultural issue is that there's no value in some organizations. Like when I was an EMT, I had no value in identifying that patient at the beginning of the call, because you're in the truck by yourself and doing your own thing. And so it's a combination of those issues. And I was just bringing that up as one of the reasons why you would at the end of the call be doing those demographics, patient name, date of birth, demographics, identification, versus at the beginning where it would be the most useful.
Copy that. Okay, so I'm glad I asked, because again, Josh, and I hope if there's an opportunity to take a note or something on this, I think this is worthy of, again, not only a conversation in the future and not just with this group, but potentially even at the DC event or something to that effect. There's a lot of what you just described. I'm glad you mentioned culture, Andrea. I think it's important. The idea that once upon a time, folks may not have seen such value. Maybe there was or there wasn't such value. That's a different conversation. But to the degree that now there's a lot of focus on, for example, access to Pulsed. Well, we've got separate conversations going on whether you would be able to look up such patient critical wishes, right? You're not going to be able to do any of that if you don't understand who this person is or have some idea of who this person is. So I think that's an education point, right? Because while if you've been documenting at the station for your entire career and someone has not laid out for you why it's worth learning to do it a different way, then there's no incentive, you're absolutely right, to do it a different way. But if we have a bulleted list of all the things you'd be able to do, and by the way, if you're able to look at Wishin and pull in demographics and past medical history and contact info and insurance, and you're able to do all of that in real time, and it saves you 10 minutes per chart to do that, that's a real incentive, right? Not a clinical incentive. That's a real workflow. Get back to whatever else you're doing and have some time to eat and sleep and have wellness in your life incentive. So I think that's an education point that gets glossed over of, are we discussing why doing it back at the station may be the way you've always done it, but it may also be time to change that. And in order to justify doing that, we need to stack value propositions and have people find it worth learning to do it a different way. Put the network in the truck, because that way you'll be able to look at the HIE. Well, why do I need to look at the HIE? And now we're off to the races, right? That is not a gloss over topic. That is the topic. So I think if again, when we talk about how that translates to design and usability and access to information and where investments need to happen, like having networks in the truck, all of those things all wrap around each other. They're not like complicated, but they all kind of get thrown out with this question of, should I chart in this? Well, I can't because I need to do patient care. You actually are doing patient care if you know that the patient's a hemophiliac, because you can look them up and you wouldn't have known that. I have a case in my inbox right now, Josh, that I got yesterday about a patient who died in the back of a truck because the patient was a hemophiliac, the medics didn't know, and the spouse got there too late. Right? What if they had the ability to look that up and they knew that information? What would they have done differently? And now everything changes. So it really is a much more involved question of well, I do this back at the station because whatever, but what if I didn't? What's the value in doing it a different way? And there's a lot of us who have a lot of stake in that conversation who are represented here. I don't think that's worth glossing over. It's worth at some point digging into pretty deeply.
Great. Yeah, thanks, Jonathan. On today's call, we're really identifying the profiles and standards that the software would implement. And then as we look at the first few calls of 2024, we're going to be talking about those questions of what is the information that the EMT should have access to. These standards and profiles would be the technical ways to actually interact with the network. But then you've got the whole question, like you're saying, of, okay, I've gotten some stuff from a network. What is it that's actually important about that? What am I going to show to the EMT on their device? So yeah, we will be getting to that. In the interest of time, I want to move forward to make sure we have enough time for Lee. He has prepared some information about enterprise master patient indexes. And then after that, we'll move to CareEvolution. Sorry to have to cut it short a little bit. There's been lots of discussion and I feel like there's more to unpack. But Lee, go ahead and I'll turn off my screen share and turn it to you.
Josh, let me just get my share set up here. Get Zoom out of my way. There we go. It's probably in your way. Okay, can you see my screen okay, Josh?
Yeah, it looks good.
Great. Okay. Well, thanks all for letting me bend your ear on EMPI today. I'm the Senior Director of Interoperability at ESO. I'm part of the product group there. My background is in automated patient record matching and clinical data integration. Came to ESO as part of an acquisition in August of last year. Prior to that, I was the CEO of Occam Technologies, which is an EMPI company. At ESO, we always start every presentation with our mission, which is to improve community health and safety through the power of data, which lines up beautifully with the work you all are doing here. So just really 3 quick points on the agenda to get through today. We're going to ground the discussion with some words from our Chief Medical Officer, Dr. Brent Myers first. Unfortunately, he couldn't be here, so I have just 2 minutes worth of recorded context from him. And then really, what is an EMPI, how it works, et cetera, and what are the moving pieces? And then finally, what can be done in situations where EMS doesn't have enough demographic information to confidently establish the patient's identity, which we've touched on here a little bit already. So let's go ahead and kick this off. I'm just realizing I didn't do my screen share properly. You're not going to hear Brent if I don't redo it. So let me just stop and reshare. There we go. That should work. Okay, here we go.
Good day, and I'm sorry I can't be there today. We have a conflicting board of directors meeting, so my apologies for not being there. I wanted to take just a couple of moments to kind of set the stage for how I think the industry should be viewing all patient matching, and there's a lot of different uses for that. So I just want to give a kind of an overview, and then certainly I'll hand it over to Lee to walk through exactly how all of this works. But there's always been the need to match an EMS patient with a larger medical record. And there are many uses for this. One of those would be a retrospective research review, or there might be surveillance by the CDC or a state repository that wants to track a particular disease process through an epidemic like COVID or something like that. There's also this need to know about a patient in real time while you're caring for the patient at the bedside, and that really takes 2 varieties. One of those is I'm the EMS provider in the field, and I need to know about my patient while I'm taking care of them. And then the others at that time of patient transfer, wherever that patient transfer may be it an emergency department, be it at a detox center, be it virtually over telemedicine. And then finally, there's this need to track a patient continuously. We need to know if there's a patient that's in our system for MIHCP, so forth and so on. And we want to know their longitudinal experience within either our system or within the community. And the list goes on. But I think the key components are the accuracy and timeliness of the match and the ability of whatever solution we have to meet as many, if not all, of those needs as possible. So when we think about that, the one thing that we can't really think about is adding manual workflow for the vast majority of patients to either a paramedic, an EMT, a firefighter, a nurse, or physician's workflow. We know that if things are kind of unnatural in a workflow, they're not going to be done consistently. So what we need and what we're looking for is a timely, accurate match that can occur basically in the background without additional work by the paramedic, the nurse, or any of the other healthcare providers. And it's got to meet all three of those criteria: one for a continuous record, one for accurate retrospective looks for surveillance and research and benchmarking, et cetera, and perhaps most importantly, at the patient side at the time we need the data, be it in the field or be it at the time of patient transfer. And I think what we're going to describe is kind of our view of how that best can be accomplished.
Okay, now you're back to me. Let's talk really quickly about the problem we're solving here. So in our last couple of meetings, Steve Rotman from Wishin pointed out the problem that can be caused if demographic information, as he described it, didn't match exactly. So, and that is a pretty significant issue. It's why EMPI is a thing, right? So, patient matching really can be sort of the major headache for interoperability, or the sand in the gears, if you will. So let's talk about, dig into that a little bit, just a couple of layers deeper here. So first, we don't have a dependable, unique identifier, so we're stuck using demographic information to identify our patients. Demographic information is a mess, as we can all attest. It's forever changing. It's incomplete. And so we're stuck using demographic information. Well, what then do we have to be able to do effectively to make use of that demographic information? So first is being able to tell the difference. We know there's going to be difference in the data. It doesn't mean that two records don't belong to the same person. But in order to automate those decisions, even when there are differences, we need to be able to recognize or differentiate between explainable differences and those we can't expect or explain, right? So two different spellings of the same name, for example, or a difference in date of birth. So here's a common one in date of birth, dropping the tens digit so that November 23rd becomes November 3rd. And then there are fully expected differences where the data is completely different. So, people change their phone numbers, they move, as in this case. People get married, people get divorced, so last names change, et cetera, right? So there are many different explainable differences to expect, both in terms of data entry issues and other issues that are just more inherent to the data. So those are, examples of cases where there are differences in the data, but can be explained where the person still might belong to the same, two different records may belong to the same person. The flip side of that coin are false positive examples where you have data that looks incredibly similar, but may just belong to two different people. So if you show this example, Jaden versus Hayden, to a group of 10 people, and just ask them what they think, and generally it would be with a full complement of demographic information. But in this case, I'm trying to make it easy to visualize on your Zoom. If, half of that room would say, oh yeah, J and H are right next to each other on the keyboard, that could be a data entry. That's probably a data entry issue. The other side, the other half of the room might recognize that they're potentially twins. And the fact is, there is no way, even with a full complement of demographic information, to be able to tell in many cases whether those two records belong to the same person or not, without some follow-up. Now, it's different, of course, if you have the patient in front of you and it can ask clarifying questions, and they happen to be conscious, but of course that's not always the case. So twins or multiple births, real common example of those, as are junior seniors and just people with baby boomers with common names, right? So those are the sort of big problems to solve. I'm going to talk, and just for the sake of time, I'm going to try and zoom through this because I know we have another presenter as well. So I just have a couple of more minutes here. So let's talk about the four major components of an EMPI. The first section, as you'd probably expect, is the match algorithms, which is all about being able to locate every reasonable match, even if demographic information is missing or wrong. And then once we have those potential matches, and especially in a good sized data set, it's going to be a lot of potential matches, could be in the hundreds. Then it's a matter of narrowing down that list by assessing the quality of each one of those matches, being able to, again, recognize the explainable differences from those that might indicate a false positive. And at the end of the day, sort those matches into one of two buckets. The first is what we think of as the yes bucket. So take it to the bank. These records belong to the same person without any further manual review necessary. And on average, in our experience, you can expect about 90% of those to get a real high quality match and automate that. And then that other 10% falls in the maybe bucket. Of course, the maybe bucket is what makes this challenging because there just isn't enough current demographic information to make that automated decision. We need more research to confirm it. The problem, of course, as we've alluded to here indirectly several times over, is the fact that as long as you don't have a confirmed match, that whether it's made by a human being or made automatically before or after or whenever, that data is invisible to the people that would benefit from it. All right, so that's the quickest explanation I can give of algorithms. Once we've done our matching, then it's a matter of keeping track of all those matches in an index. That's the I part of the EMPI. So we're keeping track of all those linked person and encounter records so that we end up having a path from your record, whatever that perspective is, whether it's from the hospital side of things or from the EMS side of things or at the state, sort of having a path to all of the other places that person has data so that we have a linked identifiers across all those data sources. That's the index. Now we mentioned maybe matches, being a problem. Not all of these matches can be automated. So workflow or data stewardship workflow in particular is one of the ways that EMPI solve this problem of being able to put these pairs of records in front of a human being that's good at doing this kind of research and making those decisions and workflow that, lets them crank through it pretty quickly and make those decisions. So you can just think of that as a work list effectively for all those maybe matches. And then an alternative to workflow is this idea of reference data that you may well be available or may be familiar with. So all modern EMPI technology has this capability to use semi-public reference data to automate matches that would otherwise require additional research, right? So if you think of those maybe matches, take the challenging real life example of someone who's gotten married and moved. So the demographic information has shifted a lot. The last name is different. The address is different, right? So it might be all that you have that actually matches across those two records is, a first name and date of birth, right? If that's all you have to go on, you're not going to make that match. Whereas with reference data, you can sort of fill in the gaps and automate a lot more of those decisions. All right, so those are the big four pieces, and this is my last slide. Again, going to zoom through this pretty quickly. So I want to just tie in how EMPI relates to EMPS. So to EMS, sorry. If I go back to Brent's suggestion, I would summarize it as this idea of automating the match and as much of this interoperability solution as possible in the background, wherever we can and whatever use cases we can, is the difference between, hey, here's this information that is relevant to you and making the provider, search for it when data may or may not exist in the place that they're searching. So I want to make sure that I get to Josh's agenda up front. So this question of how EMS can still get hospital outcome data when demographic information was incomplete to begin with. So if I could refer to the diagram here, now we're talking about getting discharge information. It might be a discharge summary, but from the hospital. So we have outcomes that we want to get back to EMS. So in a hospital setting, now I don't know how this translates necessarily to the HIE world, but we have the opportunity for a trauma nurse to get involved and manually enter a hospital account number. And then EMS today, in many cases, is manually capturing hospital account numbers and making sure that they're associated with their PCRs as well. So that's two ways that those maybe matches are dealt with today when there isn't enough demographic information. And I've covered the third, potential as well, which is getting a data steward involved. So that who knows where that data steward sits, but again, a human being whose job it is to resolve those matches that couldn't be automated. All right, and with that, I will stop sharing and turn it back over to you, Josh.
Lee, thanks for that overview of master patient indexes. In the interest of time, I'm sorry that we won't be able to have discussion and questions. I want to go straight to CareEvolution. And Trent and your team, if you can capture your piece in about 10 minutes, that would be great so that we can have a little time for wrap up. Sorry again for getting it a little bit pinched on time today, but there's been lots of discussion.
No problem. I can talk fast. Could you make me a presenter, please?
You should be able to share screen. Go ahead and try it.
Oh, cool. Let's do that. Excellent.
Okay.
So I'm Dan Conson from CareEvolution. We got a couple of other folks here from our tech team. Just real quick background: CareEvolution is a technology provider that has been working in the industry for close to 20 years now. We've done a lot of work with many different types of organizations, but the key goal has always been data interoperability, not necessarily focused on EMS, but we've done a lot of work in things like, state HIEs, kind of private HIEs and collaboratives, organizations that seek to aggregate data and combine it to do things like syndromic surveillance or, monitoring disease outbreaks. And in many of these situations, MPI has been, a key consideration, as it, always is when you're doing some sort of interoperability work. So that's just our background, and I think we wanted to kind of share some of our perspectives in that, we have actually, implemented, PICS and XDS sort of flows at state HIEs. Today, we still run the South Carolina Health Information Exchange. Prior, we've operated West Virginia, Georgia, Pennsylvania, a couple of other places like that, and so just wanted to share some of our experience, maybe from the opposite side of the perspective, and this task group might typically be involved in. We had a few kind of workflow, related slides, but we may have actually covered a few of these. I don't know, Bindu, if there's any additional flavor we want to add on this or XCA and XCPD.
Not really, Dan. I think the rest of the discussion we should focus based on the requirements specific to the EMS workflows, but these two high-level ones, I think maybe we can focus on XCPD, XCA. It could also, instead of XCPD, you can talk about PDQ. Essentially, the acronyms aside, what this means is that you start with, the starting point is, and I'm going to take the happy path here, where you do know some demographics on the patient, and you're trying to figure out what history. This is at the initial part of the interaction, I'm guessing. I'm sorry, I'm still very new to this whole the workflow. So at the beginning of the interaction, if you're looking for information or history of the patient, like someone was mentioning, that kind of history becomes invaluable when you're trying to take care of them in the back of an ambulance. So based on, say you have the driver's license, based on demographics that you have available, the EMS provider can talk to a local HIE that they're already a participant in. So you have the demographics. You can initiate a patient demographic query, get back an identifier if there is a match. And using that identifier, you do what is called an XDS, which is a query for documents. And how the local HIE handles that is they may have documents from other hospitals in the area that are also participants of the local HIE, or the HIE might do a cross-gateway document query or a cross-community document query to other exchanges in the region to see if they have history on the patient. But to the initiator of the query, which is the EMS system in this case, all of that should be transparent. You shouldn't have to talk to your local HIE and then the remote communities as well separately. If it's done right, the starting point is essentially the patient demographic query or an XCPD query, or if you are, it could be a PICS, to be really honest. So I don't think we should get hung up on the technical details there. We can get into those if the group wants to. But once you have an identifier for this patient, you go on to request documents, which is again a two-step process, which is a document, the document query, which gets you back the document metadata. And you can choose, because the document metadata will tell you recent admission or an old admission. Is it a hospital visit? Is it an ER visit, or was it an outpatient visit? Based on that, you can choose to retrieve whichever documents that you'd like to get into more detail on, which is then the XCA retrieve.
Cool. Yeah, one more thing we thought we actually might want to put on the group's radar. This is not, necessarily super well implemented today, but kind of as standards move more towards FHIR-based exchange, which to date they honestly have not been. I think when it comes to clinical data exchange between provider organizations or EMS, but typically patient access has been kind of driving that forward. But we expect this to kind of change going forward. I think a lot more folks are getting on board with FHIR. There's an equivalent kind of profile, or in the FHIR language, it's a operation is called patient match, which at a conceptual level works exactly like a lot of the other standards and profiles we've discussed, where you can post this to a FHIR server. There's a patient match operation. You provide some set of demographics, and it will return to you what it thinks matches are based on some internal MPI logic that's implemented at that FHIR server. Again, we don't see this in the industry too much yet, but maybe something to keep on the group's radar going forward. I wanted to cover a couple of kind of general MPI concepts too. I think some of this may just echo some of what Lee was saying earlier, but this is definitely something we've seen. Folks can get hung up on or get into trouble, using MPI solutions, especially at cross-organizational state exchanges and things like that. A big deal, I think, with MPI is the idea of false positive versus false negative match risks. I think they are both there. False negative, as we discussed, is when you do not get a match, even though it is in fact data about the same individual. This can cause issues. But the much worse risk to avoid is false positive, just because false negative tends to kind of be the status quo of the world today. If there is no EMPI, then everything's a false negative. So you're not really making the problem worse by doing that. But a false positive can cause some serious harm, because at that point you are both disclosing someone else's private data to someone that shouldn't have access to it, and also there's a great risk of medical errors because you are presenting the wrong data to an individual that might be acting on that. So we found that, while both are big things to worry about, minimizing false positive risks is kind of the right and responsible thing to do, which unfortunately is a bit at odds with kind of the variety of data and the discrepancies that we find and the explainable variations within the industry.
Dan?
Yes.
We are still seeing the XCPD XCA screen.
Really?
Have you switched?
Sorry
There
about that. I have this slide. This is being recorded, so I'm sure someone can look back at it later. the state of the industry, I think this kind of stuff does become a problem, and we have some quotes from some industry papers around issues. The summary of it is, this is not really a very well solved problem. There still are a lot of issues, especially when it comes to cross-organizational patient matching. There are, more issues than within a typical EMPI implementation, just because you have mostly a wider variety of data, different kind of time points when the data was taken, allowing more ability for folks to move or change addresses or, change their names and so on. Unfortunately, this is also an equity issue in that there seems to be more issues of false positive matching among more underserved populations traditionally in the field. And I think, this point at the bottom, again, puts a fine point on the false positive risk. Every mismatched record puts two patients at risk: the person whose data is inadvertently exposed, and then the person who is being falsely matched and may have wrong data in their record. So typically, a lot of MPI discussion tends to focus on data variability and, people move, people have nicknames, there's typos, that kind of thing. Here's a slide focusing kind of on the opposite, where, some combinations of identifiers, while intuitively may seem very unique and identifiable, are not always that way. So first name, last name, and date of birth is a common one. I think a lot of people assume that that's a pretty good identifier for an individual, but at large kind of population scales, that tends to not be the case. So there's obviously some very, very common names that are out there, James Smith, Brian Johnson, et cetera. And some of those people may just share a date of birth. So if that's the only criteria you're going by, this does put you at a somewhat higher risk of false positive matches. There's also kind of this interesting quirk that names and dates of births are not independent variables, so to speak. So, there's a lot more girls named Carol born on Christmas Day than a lot of other days. And, there's certain cases where there's a lot of babies named Katrina born in August 2009 because there happened to be a hurricane with that name. So, these are sort of combinations where false positive risks may seem, unintuitive, but are actually risky. Things like people assume zip code, could be added, and maybe that is really good for uniquely identifying individuals, which, obviously helps. But there you run into issues of, ethnic enclaves and things like that, where certain populations, based on their their history or origin, have certain common last names. So a good example is 50% of South Koreans have one of three last names. So somebody with a common first name and one of these last names in a zip code that has a high South Korean population, that may not be very uniquely identifying at all. Once you get more specific, with a full contact point such as an address or a phone, I think that becomes a bit different. If there's someone with a common name and date of birth living at a specific address, that's probably a good enough way to identify someone. But even then, I think when you go too far in the opposite direction and start to get loosey-goosey with requirements for names and misspellings and date of birth transpositions, address actually can be risky again, because not every address is a single family home, right? There are certain cases where you might have an apartment building where the apartment number is not listed, and just going by, first name, date of birth, and street address, there might be, a couple of people named Dan at that apartment building with this date of birth. Or, also things like homeless shelters, skilled nursing facilities, et cetera, also come into place. And twins, I think Lee covered this, it's very big kind of challenge for MPI in general, just because these are people that obviously have the same date of birth. A lot of the time they might live at the same address. And a lot of parents think that giving twins similar names is cute. So it tends to cause some issues. So here's just kind of our perspective on what we consider high quality demographics that can result in a high quality patient match, especially when you're talking about doing it in an automated fashion, as opposed to requiring manual review and referencing other data. Typically things like first name, last name, date of birth, gender, with non-specific identifiers tend to be problematic. Once you get into, things like contact info and addresses, that is helpful, but then you introduce the risk of false negatives because people move or change phone numbers. And once you have government or insurance identifiers or driver's license numbers, things like that are very specific identifiers, you can obviously do a lot better matching with even with variations in names and date of birth transpositions and things like that. In some cases, depending on implementations of linking algorithms, having more data, with address and government identifiers and things like that can actually help a healthcare data store, just because sometimes you can cross-reference, maybe that records A and B are the same individual and B and C are the same individual. You can infer that, A and C are the same individual. So that's kind of this idea of a transitive closure, which can be quite handy if many of the records have a lot of identifiers provided, even if they do not all match perfectly. That's all the remarks we had. Looks like we still have a couple of minutes. I don't know if anyone has any questions or anything like that. I'd be happy to talk about that. Thanks.
Yeah, Dan and Bindu, thanks for sharing those considerations with us. That's important to think about these things, that where we might think, oh, this is very likely to be a match, and then it turns out being a false positive because of some of those considerations you shared with us. So thank you. I apologize we don't have more time today. I would have liked to open it up for some discussion, but we are just bumping up on the end of our call. Lisa, if you could put the link to the survey in the chat, that would be great. After you get off this call, if y'all could snap this QR code or hit the link to the survey for this call, we'd like to just know how well we covered the topic, how completely we covered it. Personally, I feel like we left a whole bunch of stuff undiscussed, so we might need to come back to this topic, but we'll look at your feedback through the survey to determine that. And then I wanted to mention, going forward, we will have, of course, the ONC Annual Meeting and EMS Data Summit in December, so we will not have this task force call. But as we look at early next year, looking at the topics of what's the information that's needed by EMS and hospital staff. So for example, when EMS is on a call and they need the patient's medical history, what is it that they need that's going to help them to treat that patient? And we know about things like medications, allergies. We heard today about hemophilia. We know about pulse, all those things. So what's important for them to know? We've identified the data standards that would be used to potentially transport that information, but now it moves on to the question of what actually needs to be shown to the EMT or to the hospital staff when a patient gets to the hospital. In order to answer that question, we need those perspectives from the people who do the clinical work. And so between now and January, if you have ideas about people who could help contribute to that question that really bring more of that clinical and operational perspective, then shoot an email to me, and I'd be happy to talk with you and with them and see if we can get some good representation on those calls for that topic. Okay, well, we are right at the hour-and-a-half mark, so I'll let you all go, but appreciate all of your participation today. We'll look forward to the survey responses to see if we need to come back and cover some more on this topic. Thanks, everyone, and hope you have a great rest of the day.